In this audio, I'm covering Chapter 54, Care of Patients with Esophageal Problems. Gastroesophageal reflux, um, or GERD, is a disease that occurs from stomach contents entering the esophagus. The lower esophageal sphincter allows contents back into the esophagus. You might think that well, that doesn't seem like a problem because food started in the esophagus before the stomach. But it's important to know that the stomach is much more acidic than the esophagus. The esophagus can begin to erode from this acidity after time. Individuals who have episodes of gastroesophageal reflux are considered to have reflux esophagitis, which is inflammation of the mucosa. Those that are overweight are at an increased risk for GERD. The increased pressure in the abdomen applies force to the lower esophageal sphincter. Hiatal hernias occur when the stomach bulges through the diaphragm. Hiatal hernias increase the risk of GERD in individuals. H. pylori can also contribute by causing gastritis, which is inflammation of the stomach. When the body is trying to heal, it can substitute normal epithelium for Barrett's epithelium. Barrett's epithelium is considered to be a metaplasia of the tissue, and it can be cancerous. When the body is trying to heal, scarring is also present and can produce a stricture or narrowing of the esophagus. What do you think the patient would have trouble doing? Swallowing. GERD can lead to aspiration pneumonia, dental disease, and laryngitis. Causes of GERD are related to caffeine intake from coffee, tea, and sodas, chocolate, citrus, tomatoes or ketchup, cigarette smoking, alcohol, and high levels of estrogen and progesterone are all causes of GERD. The symptoms of GERD are indigestion, dysphagia, odynophagia, belching, gas, nausea, and dental caries. Regurgitation is the flow of food into the throat from the stomach. It's important to remember that lying down can be bothersome for these patients as well. EGDs are performed to visualize the esophagus. pH monitoring is also done to determine GERD and is the most accurate way. With the pH test, the patient should keep a record of what they are doing when the symptoms are occurring or what they are eating when the symptoms are occurring. Now, GERD can be controlled through diet as well as drug therapy. The patient should eliminate foods that cause heartburn because of irritation to the tissue. The patient should eat 4 to 6 small meals each day instead of 3 large meals. The patient should avoid eating 3 hours prior to bedtime. Eating food slowly can help to reduce the belching. Elevating the head of the bed is beneficial for some. Drugs such as antacids, histamine blockers, and proton pump inhibitors are offered. Nissen fundoplication can be a surgical treatment for patients with GERD when diet and drug therapy are not effective. Moving on to hiatal hernia on page 1114. This occurs when the stomach protrudes into the diaphragm. There are 2 major types of hiatal hernias. We have sliding hernias and periesophageal or rolling hernias. Sliding hernias move in and out of the chest during position or pressure changes, and they're most often caused by weak muscles. Paraesophageal or rolling hernias, those occur when the fundus enters the chest. They're caused by a location defect or from a sliding hernia repair. Now, whenever we're gathering an intake and an assessment on this patient, we want to make sure that we're asking the patient about any heartburn, any pain, dysphagia, and any eructation or belching. Okay, we want to make sure we're noting the nutrition status for the patient, and we also want to know the location, duration, and when the onset of the pain happens, and if there's anything that they do that relieve the pain or make it worse, such as if they're avoiding spicy foods and the pain subsides, or are they laying down and going to sleep at night and the pain happens. Okay, symptoms resulting from a hiatal hernia typically worsen after a meal or when the patient is in a supine position. Okay, and supine is on our back, prone is on our stomach. Patients can also report feeling very full after eating, or they might have a feeling of suffocation if their hernia compromises their respiratory. Now, the barium swallow study is the best for identifying hiatal hernia. EGDs can be performed as well. Non-surgical management includes antacids and proton pump inhibitors, as well as nutrition therapy or diet therapy. And for hernias, the same diet applies as discussed for GERD. Surgical management. Most oftentimes, the surgeon will want the patient to lose weight before the surgery and to stop smoking before the surgery. Now, a laparoscopic Nissen fundoplication, or LNF, that's a surgery that can be performed for those that have the hernia, for gastroesophageal reflux disease or a hernia repair. Now, it's important to remember that after surgery, for those patients that have transthoracic surgical approaches, most often they'll have an NG tube, and their oral intake is started very gradually. They want to make sure that peristalsis is stimulated or established before giving things orally. Now, the most important thing we want to make sure that we're doing for these patients is helping to alleviate their pain. Okay, the patient's head of bed needs to be elevated at least 30 degrees, and that helps to promote lung expansion for those individuals. We want to make sure that we're helping them to support the incision. These can be very painful, and the patients don't want to take deep breaths, so we really need to instruct them why it's important for deep breaths. If you'll take a look at chart 54.5 on page 1116, that's Patient and Family Education, Preparing for Self-Management. Take a review over that. Now, the drainage from NG tubes, initially it will be a dark color, a dark brown color, and have old blood in it. Now, the drainage should become a yellow-green color within the first 8 hours after surgery. We want to make sure that we're checking that NG tube for proper placement in the stomach. Now, if we do see any bleeding in the NG tube after that initial 8 hours, that could mean there's a bleed. Now, when we start these patients on their first oral feedings, remember they come out with that NG tube, and we initiate the clear liquids very gradually for these patients. Temporary dysphagia is common. Okay, a common complication of the surgery is when patients are unable to belch. And then some patients have air swallowing, and we want to make sure that these patients are eating and drinking slowly and chewing all of their food very, very thoroughly. Now, the use of stool softeners is highly recommended for these patients until their healing is complete. We don't want to put any additional stress on that incision. We want to make sure that these patients are also able to take care of themselves at home and that they can identify any signs of infection. Okay. Now, it's important also to keep those lungs expanded and having them turn, cough, deep breathe, and using their incentive spirometer. Now, esophageal tumors, most esophageal tumors are malignant. typically squamous cell carcinomas in the esophagus. Adenocarcinomas are typically found in the lower part of the gastroesophageal junction, and they're the most common type of esophageal cancer. Esophageal tumors do grow rapidly, and there's typically spread of the tumors or metastasis to the lymph nodes. More than half of esophageal cancers do metastasize. Risks are smoking and obesity. Malnutrition can also be a risk, as well as untreated GERD and excessive alcohol intake. We want to make sure that when we're gathering a history on these patients that we are assessing any history of alcohol consumption, tobacco use. We want to know their dietary habits, and we want to know if they're suffering from any problems such as dysphagia or any type of reflux. Now, it's important for us to assess for any type of vomiting, foul breath, any type of hiccups, or regurgitation, because those can accompany advanced disease. I will pick up in the next audio with psychosocial assessment.